Hello everyone. Thanks for joining. I am Dr. Pallavi Patil. I am a dentist practicing in Pune. Today we have gathered here on this forum to listen to the eminent oncosurgeon Dr. Bhushan Bhargat. He has his OPD in Viman Nagar, Pune. He operates all over Pune and at the major hospitals like Ruby, Jahangir and Sahyadri hospitals. He will be talking on oral and maxillofacial cancers. Okay, without wasting much time, I will hand over to the Dr. Bhushan Bhargat.
Thank you so much for the introduction, Dr. Pallavi. I will be sharing my slide and will start the presentation. So the topic is basically oral and maxillofacial cancer, and it's focused on dentists, especially to the BDS people who should be able to do biopsies, should be able to take decisions regarding cancers, and also will help oral surgeons to improve their knowledge on oral and maxillofacial cancers. I am Dr. Bhushan Bhalgat. I am a cancer surgeon. I am a MBBS from KEM Hospital, Mumbai, followed by MS and MCH from government medical colleges, respectively from Aurangabad and Jaipur. I do practice at my OPD in Viman Nagar, and I operate, like Dr. Pallavi said, starting from Nigdi to Katras and from Kothuru to Wagholi, everywhere. I'm a freelancer. I do my major cases at Ruby, Sahyadri, and Jahangir. So without wasting much time, this will be the overview about the topic. We will be talking about ulcers. Are all ulcers to be considered cancerous ulcers? Or are there other causes of ulcers? We always miss that. We just think about two things. One is aphthous ulcer and one is cancerous ulcer. No, there are many other causes of oral ulcers. And how to differentiate them clinically, I have mentioned. Apart from that, what are the causes of oral cancer? We think that tobacco is the only cause of oral cancer, but no, there are multiple causes which are coming up as the causes of oral cancers. Apart from that, we will be discussing on dental extractions in cancer patient, a very common question asked by patients to me, asked by dentists who are treating my cancer patients regarding, can we remove the tooth after cancer treatment, during cancer treatment? So we'll be talking about that. How to take a biopsy about any suspicious ulcer. That can be done in an OPD basis on your own dental chair. So it's very easy. We'll be discussing about that also. What exact test you should be getting done from the patient, because once a patient comes to you with a biopsy, or either you to get a biopsy done, rather than calling an oncosurgeon up next, what to do next, you should know either to get a CT, whether to get a PET scan, whether to get an MRI for that patient, and which kind of CT or MRI should be done. We'll be talking about that. Apart from that, some surgical aspects, basic aspects which patients ask the dentist who is treating them, like मेरा कितना जबड़ा या फिर मैंडिबल निकाला जाएगा, क्या मैं बोल पाऊंगा, क्या मैं खा पाऊंगा, रिकंस्ट्रक्शन कैसे किया जाएगा, मतलब कहाँ से कोई चमड़ा लगाया जाएगा, फ्लैप लगाया जाएगा. These questions are asked by patients to you also and to us also. So if you are able to handle those questions at the baseline level, the patient becomes satisfied, less anxious, and more confident to go to oncosurgeon for the surgery. So these are the topics. I will not be focusing on types of cancer. I'll not be focusing on what are the squamous ulcer, adenocarcinoma, pharyngeal, laryngeal. No, we'll be talking on very practical points which you should know on a baseline level as a dentist. So the definition of ulcer is basically a crater which is formed due to destruction of the mucosa and the connective tissue. That is called as an ulcer. Common causes of oral ulcer. Most common is the aphthous ulcer, that is recurrent aphthous ulcer, RAU. The other causes of oral ulcers are cancer, tuberculosis, trauma. So how to differentiate? Basically, aphthous ulcers have a very typical red colored halo around the ulcer. Tubercular ulcers are dirty looking ulcers, foul smelling ulcers. Traumatic ulcers have a typical history of trauma to the tooth by a sharp tooth. If you examine properly, you will be able to see the traumatic tooth. And cancerous ulcers have a history of coming up very, very fast. And especially on the lateral borders of tongue, where the sharp tooth has been hitting, or where the tobacco has been kept in the GB sulcus, especially those areas, ulcers develop, cancerous ulcer develop. So clinically also, if you see at the pictures, you can differentiate how aphthous ulcer looks different from a tubercular ulcer, from the traumatic ulcer, and a cancer ulcer's photograph will be following soon, how to differentiate these easily by looking at them. Now, if you are not able, usually ulcer patient comes to you and you give multivitamins, you give some painkillers, you give choline salicylate to reduce the pain, you give some steroids to reduce the ulcer size and pain. Apart from that, even after giving all this treatment, some patients still have the ulcers. So what you have to do is you can go ahead with a syphilis panel to rule out syphilis related ulcer. You get a HIV test of that patient to know whether the patient is suffering from a HIV related disease. Third, you check whether the patient has diabetes, because very common cause of ulcer is also can be a fungal ulcer, commonly seen in diabetic patients. So once you rule out HIV, diabetes, syphilis, aphthous ulcer, tubercular ulcer, then you might think कि क्या ये ulcer cancer ulcer है. But remember one very important point. Any ulcer which has not healed over a period of 2 weeks or a period of 15 days, even after giving complete treatment of multivitamins, antibiotics, everything, then you go ahead with a biopsy. So basically, a 2 week period is a must period to diagnose a cancer ulcer. Now, where was this data or where was this taken from? You can read about the types of ulcer, types of cancer ulcers from this PDF. It's the International Journal of Oral Science, where very good guidelines for diagnosis of oral cancer have been given. So you can go ahead, IJOS ulcer journal, to check about more about the ulcers types and diagnosis. Just a minute. So now coming to causes of oral ulcers, oral cancers, not oral ulcers. We have talked about oral ulcers, the oral cancers. So you think that tobacco is the only cause of oral ulcer? No, tobacco is the most common cause of oral ulcer. Apart from that, the second most common cause of oral cancer, which is coming up, is chronic trauma or a sharp tooth. If the tongue is repeatedly being irritated by a sharp tooth, which is partially removed, there are sharp edges, then it could be a common cause of oral cancer. Apart from that, in the foreign countries, HPV is a known case of oropharyngeal cancer, but it's coming up in research as a cause of oral cancers also. Less known, alcohol is a cause of oral cancer also, apart from liver cancers. And genetics, definitely. If your father has an oral cancer, you have a slightly increased risk. Not much, a slightly increased risk of oral cancer. The genetic risk is lesser in oral cancers compared to breast and ovarian cancer, but it has to be mentioned. Now, regarding dental extractions, how safe is it in cancer patients? बहुत बार क्या होता है, patients ask the dentist, right now I have undergone a cancer surgery, only the mandibulectomy had been done, maxilla के teeth वही पे है वही है, there is some cavity or there is some infection which requires extraction, so can I get those tooth out? I have, so very important, if radiation has been given in the past 6 months of the treatment, do not touch the patient for extraction. What happens is, if it is a radiated patient and you extract a tooth, and if there is some kind of infection which happens, there might be a risk of osteoradionecrosis, ORN. So if radiation has been given in the past 6 months, do not do dental extractions. Another question, which patients, not a question, which patients misguide कि मेरा दांत निकाला डेंटिस्ट ने, इसकी वजह से मुझे कैंसर हुआ. दिस इज वेरी डेंजरस. दिस इज नॉट ट्रू. पेशेंट्स थिंक दैट दांत निकालने की वजह से कैंसर हुआ. इट इज नॉट ट्रू. देयर वाज कैंसर बीनीथ दैट इन द अल्वियोलस. दांत हिलने लगा ड्यू टू द कैंसर, एंड इसलिए वो निकालने के लिए आप डेंटिस्ट के पास गए. डेंटिस्ट ने वो दांत निकाला. ये बहुत अच्छी बात हुई कि वो कैंसर दिखने लगा, एंड वी कुड गेट अ बायोप्सी. सो इट इज टोटली फॉल्स एलिगेशन इफ द पेशेंट सेज कि मैंने दांत निकलवाने गया और मुझे कैंसर हो गया. It is just that there was a cancer beneath and you got it diagnosed. That is a good thing that you have done. So do not be afraid that you see something at the alveolus or on the gums which is suspicious and the tooth is moving. Go ahead, remove the tooth, do the biopsy at the same time. So just take a proper consent. You can do it under local anesthesia or regional anesthesia. Anyways, the tooth are very loose if it is alveolar cancer. Don't be afraid कि bleeding हो जाएगा. यहाँ पे bleeding हुआ तो मैं कैसे handle करूंगी? I do not know how to take a stitch. Just simple. Remove the tooth. There is a bleeding. You put a gauze and wait for 15 minutes. Any bleeding in the body with pressure stops with 15 minutes. This is a word of an oncosurgeon. So do not be afraid to do a biopsy in your own OPD on your own dental chair. No operation theater is required. No MDS oral surgeon, no oncosurgeon is required to do a oral biopsy. How to take a biopsy? Only these two instruments are required. One is a lignocaine spray, 10%, you can see on the slide. And second is a punch biopsy forceps. Just spray it if you think the patient is very uncooperative. After the spray, you give some lignocaine, an injectable, and you take a punch biopsy. Nothing is going to happen. Send it in formalin bulb. Do not send it in normal saline. And one more thing, if your pathologist is not available, yeah, फिर you have to send a sample from a periphery to Pune or Mumbai. It might take 2 to 3 days. Don't worry. If you store the sample in formalin for 2 to 3 days, nothing is going to happen to that sample. So you can definitely take a biopsy and send it after 2 days, or you can make sure that it reaches in 2 days to a center, pathology center for histopathology. Apart from that, please, I also ask my general surgery friends. Very commonly, we have patients of piles or hemorrhoids or bleeding PR. They just do the surgery of piles. They do not check that whether there is a rectal cancer. Similarly, for oral surgeons or dentists, you do not just focus on that only ulcer. You check everything, each GB sulcus, each tooth, pharynx, tongue, palate, lips, everything you check, and only then at the end you check where the patient is focusing on. Before that, you check everything so that you do not miss a site. Very commonly, patients come with a cancer on the right side, biopsy is there. When we examine the patient as oncosurgeon before going for surgery, we see that there is another small ulcer, small leukoplakia on another side or palate, which also can be taken care of during that same surgery if we know beforehand. So check everything apart from that only ulcer. Now, what can go wrong while taking a biopsy? Sometimes biopsy can come negative. So please be aware that whether you have taken the biopsy from the necrosed part of the tumor, means the central part, please preferably take a biopsy from the edge of the ulcer. Second, if there is an exophytic ulcer, like it's coming outside like a cauliflower, do not just take a superficial biopsy from the outside part. Go to the base, take a good chunk, give pressure, bleeding will stop. And do not biopsy from the surrounding normal tissue, it is obviously going to come negative. So only remember, take a biopsy from the edge of the ulcer at the base. Now coming to imaging. Why to do imaging? Now suppose there are few patients who come to you, they have a biopsy. They say now we can see the lesion on the tongue, we can see the ulcer on the mandible. Why not go ahead with surgery directly? Surgery cannot be done directly just because the ulcer is on the lateral border of the tongue. We have to get an MRI of the tongue to see how deep it is so that we can properly excise with a 1 centimeter margin. So it helps to anatomically map the disease to plan the surgery. Secondly, if it is a recurrent disease, imaging can help us to know whether the recurrence is there or not. Third, if we have to go for guided biopsies, like if there is a surgery already done, there is a small recurrence in the node in the neck and we need to get a biopsy. So UAG, sonography helps to get a biopsy of that small node. So that is one help of imaging. And last help of imaging is to plan radiation therapy. Now, while doing a CT scan, please remember to ask the radiology technician to make a puff appearance of the face. You can see this image. This is called as a puff appearance. Why? You can see in the next slide. You can see my cursor. So this is a CT scan coronal image. You can see the teeth. You can see the buccal mucosa, and you can see this black thing in between, that is the air, because the patient has puffed. If this puff was not there, this mucosa on the lateral side and this teeth, they come together and there is no space in between. So beautifully you can see on the right side, the mucosa is normal. While on the left side, you can see there is a wavy mucosa where the arrow is pointed. So this can be noted only when there is a puff cheek appearance. So please ask While you are writing a CT scan contrast of the face for an oral cancer patient, ask the technician to get a puff cheek appearance. So CT scan is the best for oral cancers apart from tongue cancers. Now, 3D reconstruction image also help for reconstruction of maxilla and mandible. A cone beam CT, which is commonly seen in dentist OPDs or dentist diagnostic centers rather than seen in oncosurgeons OPDs or diagnostic centers. It is commonly used, easily available modality to diagnose or to map oral cancers. You can also write a cone beam CT rather than a contrast CT in some patients, early patients. This is how a cone beam CT looks like. Most of you might have seen at your institutes where you have done your residency. Now, one more thing, if the patient is a case of suspected MRI tongue, do not advise a contrast CT scan. Do not advise a contrast CT scan. Tongue requires a MRI. As you can see, a very classically defined lesion can be seen on MRI where the arrow is pointed. Now, when we know that this is the lesion outside, when we see from outside in the OPD, you can just see that the lateral border of the tongue is ulcer, but the MRI shows how deep it is. So in this case, we have to go 1 centimeter beyond. You can see my cursor. It has to go at this level, 1 centimeter beyond the ulcer. Just like in this image, you can see a lateral border surface has an ulcer. You might think this is a straightforward case. We go ahead with the wide excision. No, when you see the MRI, the mid part here, it goes up to midline. You can see this white color patch on the left side, which is going up to midline. So in this case, more than a partial glossectomy is required. So more than a partial glossectomy also requires reconstruction. So MRI helps to determine which kind of reconstruction will be required, how much tongue has to be removed. So remember, oral cancers, alveolar cancer, CT scan, tongue, get a MRI. Why not PET scan? Many of you might have heard about PET scan. PET scan is a test done to know where the cancer has spread. In oral cancer setting, most common site of oral cancer spread is the lungs. And we generally do a chest x-ray or we continuously do a CT of the face and the thorax or the chest in most patients going for a surgery. So PET scan is hardly required in oral cancer cases. Other cancers, definitely PET scan is required. For follow-up, definitely PET scan is required once the treatment is over. But initially, when the patient is up for surgery, better get a CT or an MRI done. PETs can be used for the follow-up or later use in recurrent settings or later settings. Now, surgery. Very important thing for surgeons, or you should know which patients you should advise surgery, which patient you should stop and say no, you should not go ahead with surgery. You can see in the next image on the left side, this is a clear-cut image. Very good, well-defined tumor. Yes, you should go ahead with the surgery. Good margins can be taken. Patient can be assured that yes, you can be completely cured. You can see the second image. This patient is already in the operation theater. This has already been operated, but such patients, you think about it, should we operate them? No. Although मैं ये सब निकाल सकता हूं, एक सर्जन को एक फीलिंग होता है, एक सर्जन को लगता है कि yes, I am the boss, I can remove this, I can remove that, I am very skillful. Yes, you are skillful, but should you remove this? No. The survival of the patient is very poor. Yes, for palliative purpose you can, but not for curative purposes. This is patient which is a skin is involved, the mandibular alveolus is involved, it is extensive disease to the neck. So surgery would not be a good option for curative purposes. Avoid such patients. Counsel them that surgery, although we just help you for palliation, it is not going to help you for cure. Now, what are the steps of surgery? Many people think very big surgery. Commando is the biggest surgery. It takes 10 hours. No, Commando takes 3 hours. So there are 3 steps. Simple wide excision with a hemimandibulectomy or a segmental mandibulectomy or a marginal mandibulectomy. We'll talk about that. So we remove the mandible along with the tumor. We do the neck dissection and we do the flap. So basically there are 3 steps: primary, neck dissection and flap. 1 hour each. Everything takes 1 hour each. So it's a very small surgery, takes 3 hours, can be done in a routine OT setup, not require ICU. Patient is extubated on table. Patient start RT feeding next day, is mobilized next day, discharge on third day. So Commando is a very simple surgery. Explain to the patient the 3 steps. Many patients think neck क्यों कर रहे हो? कैंसर मुंह में है, तुमको फ्लैप चेस्ट से लेना है, नेक में टाके क्यों दे रहे हो? हम अच्छे नहीं दिखेंगे। मुंह के अंदर से छाला निकाल लो, और छाती से तुम फ्लैप ले रहे हो तो छाती से फ्लैप लेके डाल दो। व्हाई देयर आर स्टिचेस ऑन द नेक? यू हैव टू एक्सप्लेन that most common site of lymph node metastasis in oral cancers goes to the neck. So you have to do the neck dissection. And apart from that, the flap which comes from the chest or from the hand or from the foot has to be anastomosed in the neck. So neck dissection is required. This is a very common misunderstanding in the patients which you can rule out, you can explain to them in your own OPD before sending it to the oncosurgeon. Now margins. Like I already talked about 1 centimeter. कब से मैं 1 centimeter 1 centimeter बोल रहा हूँ? Always remember, gross margins about the tumor should be 1 centimeter around the tumor. So if this is a tumor, you have to go 1 centimeter around. You just cannot go near the ulcer or near the tumor. Minimum 1 centimeter grossly has to be there on an unstretched mucosa. When you remove it, in the formalin bulb, again the mucosa gets shrinked. So that's okay. While you remove it, it has to be 1 centimeter. Now something about frozen section. Sometimes, especially in tongue cancers, there is a doubt कि हमने जो निकाला क्या वो exactly 1 centimeter है या हम कहीं कम गिर रहे हैं. So you use something called as frozen section. What is a frozen section? It's a histopathology technique. So it is a pathology technique. It is done in 45 minutes. Patient is on table, intubated. You have done the primary tumor. You are going ahead with a neck dissection. So by the time you finish the neck dissection, the primary tumor which you have removed has to go to the frozen section laboratory. And they tell you that the margins are good enough to stop for the primary, or you have to take some extra margins. So frozen section is a technique used in the OT to make sure that you are safely taken the margins of 1 centimeter. And you can excise extra if you are less on the same time before giving a flap reconstruction. Now regarding mandibulectomy, there is a confusion regarding this in the dentist faculty also, in the patients also, कि मेरा पूरा जबड़ा निकला जाएगा, मेरा बीच का जबड़ा जाएगा, साइड का जाएगा क्या, मेरा ऊपर का आधा जाएगा, नीचे का जाएगा, ऊपर का दांत जाएगा, नीचे का दांत जाएगा, कितना दांत जाएगा? So this is a question asked. So basically, tumor अगर तीन दांत, three teeth are involved by the tumor, or the tumor is very close to those three teeth, you have to at least take 1 centimeter this side, 1 centimeter that side. Okay, so that is a margin. So mandibulectomy, in that you have to explain कि इतना दांत जाएगा ट्यूमर से 1 सेंटीमीटर इस तरफ जितना दांत है उतना पूरा जाएगा. अगर ट्यूमर अपर जीबी सल्कस में इन्वॉल्व है तो ऊपर का दांत भी जाएगा, और ऊपर इन्वॉल्व नहीं है तो ऊपर का दांत नहीं जाएगा. So this is a very confusing classification given in some textbooks, in your oral surgery textbook also, in our onco books also. Rather than that, you just remember this simple: hemimandibulectomy, lateral mandibulectomy or a segmental mandibulectomy, and a central mandibulectomy. What's the difference? In hemi, you have to remove one side completely. This is usually not done nowadays because you can save the condyle. The upper part is known as the condyle. So in most patients, the condyle can be saved. In lateral, this is the most common. The second one is the most commonly done. It is also known as the segmental mandibulectomy. Why this condyle is left? Because if you are reconstructing it with the fibula flap, fibula is a bone on the right, on the both sides, on the lateral side of the leg, which can be used by plastic surgeons to reconstruct the mandible. It's the most common flap if you are opting for a free flap in a mandible tumor. So if that has to be reconstructed, you have to have something on the condyle side. You have to have something on the medial side to connect these two. So the condyle has to be spared. And the most important thing is the central mandibulectomy. So if the center tumor is there, we have to remove the central 1/3. In that case, what happens? The right and left ramus goes like a march past, like a parade. Right and left goes up and down. So you have to connect them something like a plate or a fibula flap so that they go in sync and the patient can eat. So these are the three types of mandibulectomies. Apart from that, you can also remove mandible in this form as a marginal mandibulectomy. You can see the first image. There's only the upper half of the mandible removed. So you have removed the tooth, but you have spared the lower part of the mandibular body so that there is a sync that right and left can move in sync. So this is commonly done in early cancers. If the cancer is there in the paramandibular space, that is in the lower part, you have to remove as a segment. So the most common surgery, to be very frank, in Indian settings, the poor patients are more. Patients opting for fibula reconstruction are less. Old patients are more. So reconstruction in free flap should are not done very commonly. The most common flap or mandibulectomy is this segmental mandibulectomy, followed by a PMMC, pectoral major flap reconstruction. Now, what instruments are required is a giggly saw or a striker bone cutter, one of the two. Now, the reconstruction, क्या अभी तो निकाल दिया, what the patient asks you in the OPD, निकालने के बाद लगाएंगे क्या? The most common flap is the PMMC, pectoralis major flap, which is taken from the chest and put in the oral cavity. 80% patients go for this flap. It is not a bone flap. It is the only soft tissue flap. So although there is no tooth or teeth that can be put up in that side, but the patient is comfortably looking okay. There is no much deformity in talking, in swallowing, and in looks. The second common flap is nasolabial, taken from the lateral side of the nose. The third common flap is the radial flap, which is taken from hand. It is also commonly used on the tongue. And the fourth, which we are talking about, is a fibula flap. If the mandible is removed, a patient is young, patient is affording, patient has no other disease, we go for fibula flap. Teeth can be implanted in that fibula later on after 6 months of radiation, and the patients can be back to normal life. So the best flap is fibula flap. Most common flap is pectoralis chest flap. Now, post-surgery rehabilitation. Dental extraction should be done either 10 to 14 days before radiation starts or 6 months after radiation finishes. Do not touch in between. Speech consultation is obviously required. Swallowing therapy is required after surgery. This you have to explain to the patient, yes, you will be back to normal life. 70-80% तुम्हारा स्पीच नॉर्मल रहेगा. 70-80% तुम खा पाओगे, पी पाओगे. ज्यादातर सॉफ्ट ही खाना है. कड़क खाने में आपको अपोजिट साइड से खाना पड़ेगा. कुछ दिन गाइड प्रोस्थेसिस लगा के मैंडिबुलर शिफ्ट जो है उसको करेक्ट करना पड़ेगा. So all these things are very much required. We require a lot of prosthodontics with us in the post-op period. We require a lot of orthodontics also to correct the teeth alignments. We require a lot of endodontist because patients post-radiation, there is some kind of infection after radiation because the oral cavity is not very clean. So we require a lot of dentists, postgraduates after surgery, before surgery, along with the oncosurgery in rehabilitating the patient. Other head neck cancer which I commonly operate are tongue, base tongue, hard palate, maxilla, larynx, and pharynx. Now coming to the second important topic, this I usually add to my oral cancer topics also because apart from being dentist, every one of you has a female in the family, either mom, wife, a sister, a daughter, or you yourself are a female. So if anything is there, you must know beforehand. Apart from oral cancers, I'm talking this. Again, a Women's Day is coming, Cancer Day is coming. I need to emphasize that breast cancers, cervix cancers are preventable, completely curable if diagnosed in early stages. Many of you don't know how to go ahead, how to diagnose these cancers in yourself, in your family members, in your relatives or friends when they ask you. You you are doctors, dentists are doctors. So as a doctors, everyone has a responsibility कि अपने relatives को, किसी दोस्त को अगर कुछ सवाल पूछा है कि यार ये कैंसर हो सकता है कि अपार्ट फ्रॉम ओरल कैंसर, तो आपको मालूम चाहिए हाउ टू डायग्नोज देम अर्ली. So what are the risk factors for cervix cancer? Cervix is a thing which is there on the outer aspect of the uterus in the vagina. The most common cause of cervix cancer is human papillomavirus. Yes, HPV, which is a common cause of oropharyngeal cancers, is also the most common cause of cervix cancer. How to prevent it? Simple, you have to get a vaccine. I'll talk about it. Second, breast cancer. You can see in this chart, there are a lot of things which is the cause of breast cancer. Like if you're a female, you are at a higher risk of breast cancer, obviously. If you have a menarche early, that means your period started before 12 years of age. If your periods are ending after 55 years of age. If your mom had breast cancer, if your masi, your boji, your bua, your dadi, nani had breast cancer, then your risk increases. If you are not breastfeeding your child, your risk increases. If you are using a hormone replacement therapy, your risk increases. If you have taken some kind of radiation in the past for some other cancer on the chest, your risk increases. Apart from that, obesity, lack of exercise, eating lot of unhealthy food. Why? Because estrogen. What is the cause of breast cancer? Is estrogen. It is a normal hormone in the body of a female normally produced during the first 15 days of the cycle, if it is in excess of the normal amount, it is going to cause you breast cancer. How? Now, suppose a female has a periods starting from 12 years of age, finishing at 55 years of age or 50 years of age. In general, 35 to 40 years of periods a female undergoes. If that female has periods starting at before 12 years, so that much number of cycles are more. The number of cycles are more, the amount of estrogen in her body in her whole lifetime was more. So, number of cycles she has in her own life is directly proportional to the risk of breast cancer. Now, if she is pregnant, if one of the females has not been pregnant anytime, and one of the females has been pregnant 4 to 5 times, by meaning pregnant, the complete pregnancy, not abortions. If she has been 4 to 5 times, she has delivered a baby, and there is another female who has not delivered a single baby. Just see the comparison about the cycles. 9 months of pregnancy, the cycles are off, multiplied by 5 times if she has been 5 times pregnant. So it is total of 45 months compared to a female who has not been pregnant even once. There is a reduction of 45 cycles in that female, and so the risk of breast cancer reduces in a female who has been more times of pregnancy. Similarly, if she has been breastfeeding, 6 months, usually the periods don't come back. So 6 months of being off periods causes that much amount of reduction in estrogen hormone and reduces the risk of breast cancer. Now, prevention. How to prevent these two cancers? Is there a way? Yes. Many of you might be knowing about these vaccines. Recently, Indian-made Cervavac vaccine has come. But although you are aware, I don't think most of you have taken this vaccine. This vaccine has to be taken twice, like the COVID vaccine. Similarly, this vaccine has to be taken 2 times. If you take it today, you have to take it 6 months later. But that is when you are about age of 9 to 14 years of age. Now, the audience whom I'm talking to right now is obviously not between 9 to 14 years of age. Some are unmarried, some are married, some are more than 45. Why I'm taking this word about 45 is this vaccine can be taken by most females who are less than 45 years of age. Best time to take this vaccine is between 9 to 14 years, 14 saal, 14 years tak. If not taken in that period, after 14 years, at least up to first intercourse, if you get that vaccine during that time, it is the best time. If not during that time, at least up to 45 years of age, you get this vaccine. So if you are in between 9 to 14 of years of age, if you have a daughter, if you have a sister who is in between that age, only 2 doses are required. If the age is after 14 up to 45, 3 doses are required. Today, 1 month later, and 6 months later. So be aware, take any of these. Gardasil can be taken, Cervarix can be taken, or the latest one which has come, Indian made Cervavac. The cost is very cheap. One vaccine of Cervavac cost around 2000 rupees. I'm not advertising any vaccine, you take any of them. The Indian one costs around 2000 rupees and it is equally efficient. Now, regarding screening, most of you know even about this. What is screening? Now you can see this is a hide and seek game which we used to play in our childhood. एक जन डेन ले रहा है, 3 लोग 4 लोग छुपे हुए हैं, कोई भी आके धप्पा कर सकता है. अब ये इमेजिन करो जो डेन ले रहा है वो हम लोग हैं, या फिर वो पेशेंट नहीं कह सकते, वो एक लड़की है, a girl who is taking a den. There are 4 cancer cells which can attack her, which she can find if she plays hide. Now you can see there is one more girl which was behind that tree apart from the one taking den. So that is what screening is. Screening means finding out which is not seen easily. Like there are two kinds of females. Let me compare. Let me make it simple for you. One female doesn't have anything in the breast. She doesn't have any lump. She doesn't have any nipple discharge. She doesn't have any skin retraction, no nipple retraction. There is another female who has a lump or he has some nipple retraction. So both of them go for a mammography. The one who has a lump, obviously mammography पे कुछ ना कुछ दिखेगा. Now जिसको कुछ भी symptoms नहीं है, वो जाके जब mammography करवाती है and there is something she has found on mammography, that is called screening. जो नहीं था वो हमने ढूंढ के निकाला मैमोग्राफी से. सो मैमोग्राफी इज अ स्क्रीनिंग मेथड टू फाइंड what is not seen or palpable clinically. Who should do a mammography? So all women who are more than 40 years of age should get a mammography done once in a year. Screening. Every year, mammography, 40 years के ऊपर compulsory. Your mom at home, today go tell her, call her up. Mom, mammography कभी किया है? नहीं किया है? आज ही करना है. हर साल में एक बार करना है. Compulsory. If your age is less than 40, sonography is fine if you have any symptoms. Otherwise, screening is not required for less than 40 years of age. Now, cervix. For cervix cancer, is there any screening? Yes, it's called pap smear. Any female who is more than 20 years, 21 years of age, up to 65 years of age, should get a pap smear done once in 3 years. It's a simple brush technique. You have to get it done in the OPD by a gynecologist, by an oncosurgeon, or you can get it done by a any BMS, MS gynecologist also. So this is a simple test that can be done in the OPD basis once in 3 years for cervix cancer and mammography for breast cancers. Now, some myths. This is obviously not for directly for the dentist, but you should know that if you have any patient who have any lump in the breast who is suspected and someone has advised कि हम FNAC या सुई की जांच करके देखते हैं, no, go ahead with a biopsy. Do not go ahead with a FNAC because biopsy tells us many other things apart from just a diagnosis. When to do sono, when to do mammo. Sometimes कोई female आती है, her age is 25. शी हैज अ ब्रेस्ट लम्प. शी आस्क्स यू, यार बता मुझे कि मैमो करना है सोनो करना है, मैं कंफ्यूज हूँ. एक डॉक्टर ने मुझे सोनो बोला है, एक ने कुछ सोनो मैमो बोल रहा है, एक मैमो बोल रहा है. सिंपल है, 40 ईयर्स से कम है, ब्रेस्ट आर यूजुअली डेंस, सो मैमोग्राफी कैनॉट सी सम थिंग्स ऑन डेंस ब्रेस्ट. सो बेटर गेट अ सोनोग्राफी डन. इफ यू आर लेस देन 40, sonography. More than 40, usually the breasts are less dense, they are more fatty. So get a mammography done when you are more than 40. Simple. You also should know what is the treatment of breast cancer is surgery and chemo in early stages. In advanced stages, surgery, chemo, and radiation. And if it's stage 4, only chemo. So please see that chart. If you are in an early stage, you can be cured completely by just getting a surgery and little amount of chemo. If you go in advanced stage, you have to take chemo once or twice, plus surgery, plus radiation. And if it is stage 4, surgery is useless, radiation is useless, only chemo can be given. That is the last option. So early diagnosis of breast cancer is very important. Cervix cancer, surgery, radiation, and chemoradiation can be treated. Metastatic is stage 4, only chemotherapy. So early diagnosis, we have a lot of options. That is what I want to emphasize from this. Do not try to remember this or memorize this, not for you. Just trying to emphasize that early treatment can cause complete cure with multiple options available. Now, some cases, some oral surgery cases which I have done through these years, I've been practicing since 8 years. So these are the cases which I have operating. You can see a photograph, the tongue ulcer is in the center. You can see my cursor, I hope. Or should I use a pointer? I think the cursor can be seen, I hope. I think the laser pointer can be seen now. So this is the ulcer in between. You do not go very close to the ulcer. You have to take 1 centimeter margin. So see, the ulcer is just 1 centimeter. The patient is very early. Still, we have to excise this much amount of tumor. So remember, if the ulcer grows of this bigger size, we have to go beyond that. Partial glossectomy, total glossectomy. So this is the amount of margins we oncosurgeons take while doing cancer surgeries. This is a recurrence case. This was a skin flap. We had to again remove the cancer. Still, we took more than 1 centimeter margins. You can see the tumor is here. The margins are beyond this. This is a PMMC flap. Many of you have not seen the surgery actually. This is the chest. We take a flap from here. We have to incise on the chest. This is the flap on the right side with the nipple in the oral cavity. We have to excise the nipple and then put the flap. This is the chest. You can see the flap was taken from here. This can be closed primarily. Nothing else is required on the chest. This comes as a suture line. This is the post-operative. You can see the chest sutures. This is the L-shaped or V-shaped suture on the chest. You can see a sharp line between in the midline on the lip and on the neck. This is the kind of reconstruction a PMC can be given. This is the chest flap. We have not put a bone. We have removed the mandible. We have put the chest flap. Still, the good amount of flap, if it is put, you can see that the face cosmesis is not much hampered. Because there's no bone, obviously this is not going to be a sharp line here on the right side of the cheek, but at least it's bulky, at least it's not gone inside. You can see the beautiful flap put inside, which is very well set with the mucosa. This is the mucosa and this is the skin. It's very well merged with it. After around 2 to 3 years, you can see this is beautifully set in the oral cavity. Now some patients are advanced. You can see in this patient, the tumor on the outside, the tumor had gone outside and come out of the skin. That is called T4 disease, locally advanced. So we had to put a patch on the skin. You might have seen respected Sharad Pawar ji also. There's a small patch on the oral cavity. That similar patch, because the skin can be involved by the tumor, we have to also put a flap on the outside also if the tumor is advanced. These are some nasolabial flap pictures, immediate post-op on the right side, the male, and this is after 1 to 2 years on the left side. You can see the skin on the right side of the cheek, which was very evident in this male. After a few years in this female, the cheek line is also disappearing. So some patients are worried कि यहाँ पे cheek के आसपास कोई line आएगा, scar आएगा. Don't worry. Nasolabial flaps are safe for small tumors. You can use it for small tumors. This is the surgery of the nasolabial flap. You can see this small ulcer in the first slide, small ulcer on the RMT. This is the nasolabial flap in the second slide, which we have marked. We have raised the flap. In the fourth slide, you can see the flap is going inside. In the fifth slide, you can see the suture line, beautiful suture line on the face. And in this last slide, you can see that the tumor with the good margins have been excised and the nasolabial flap has been set. This is the free fibula flap which was done. It is a big flap. Fibula flap is the big flap taken from the foot, and you put it instead of the mandible with the skin over it. This is the kind of neck dissection we do as oncosurgeons. You can see this was a very advanced tumor. Internal jugular vein is not seen in this image because it was excised completely. Sternocleidomastoid is not there. You can see the carotid artery which goes to the brain. इसको भी पूरा छील दिया है because the nodes were very large, stuck to the multiple structures. This kind of neck dissection is done during oncosurgery neck dissection. You can see the beautiful flap. This was a cheek flap used to reconstruct the tongue. You can see the tumor on the maxilla. This is the case of maxillary cancer. So we have excised the tumor. We had to use a forehead flap. The flap from the forehead was taken and put over the maxilla, and the graft was put on the forehead. You can also, this is a very advanced disease. Some people might not like looking at this image. Viewers discretion is advised. Bilateral neck dissection, bilateral mandibulectomy, a central mandible, all the tooth. You can see molar से लेके molar तक पूरा mandible हटा दिया है. Very advanced disease. This had to be reconstructed with a big fibula flap. This locally advanced tumor also come. Unfortunately, in oral cancers, in maxillary cancers, surgery is the last and best option a patient has. So that is the kind of surgery we do in oral surgery. This was a sarcoma, a big sarcoma of the mandible. We had to remove, we had put a ALT flap from the thigh. Thanks to the plastic surgery team we have in Pune, they can do large flaps for large tumors also. This is a kind of tumor which was in the mandible going into the temporal fossa of the brain. We had to involve neurosurgeons with us for this kind of surgery. A big sarcoma you can see here in the maxilla anterior part. We had to remove the nose. We had to remove the maxilla. You see the reconstruction in the third image. We had to put a free flap, unfortunately. And nostrils had to made here near the eye. We require a lot of prosthodontics in post-operative period such patients. You can see that tumor that we excised from the nose. The second image is more accurate. For some larynx tumors, now some people might think larynx निकाल दिया तो आवाज कहाँ से आएगा? So in larynx tumor, we have something called as a voice prosthesis. You can see here, we have put it into, this is the trachea. We have removed the whole pharynx, we have removed the larynx. This is the trachea you are seeing, and this prosthesis for voice can be put. Patients can have up to some part up to normal voice can be given back even to larynx cancer patients. Now this is metal prosthesis. We have a good prosthodontic team here in Pune. Maxillary tumor was done, orbit floor was gone. We had to put a metal prosthesis in the maxilla. This is the plating we could do in some patients who are not fit for fibula flaps, but large amount of mandible has to be removed. We can put a plate and put a PMC flap over that. This is a beautiful image of a parotid duct. While doing oral surgeries, we have a parotid gland, we have a parotid duct. We have to preserve this parotid duct so that patient does not have secretions choked up in the parotid region. Apart from oral surgeries, head neck surgeons, as oral and oncosurgeons, we also do parotid cancers. This is a beautiful facial nerve coming from the right side of the face. All the five branches can be easily seen. Uh, I'm not just a head neck surgeon, I'm an oncosurgeon. I do a lot of breast surgeries, GI surgeries, gynec oncosurgeries. So this is a breast lump we did under local. You can see the size of the tumor. You might say सर ट्यूमर तो दिख ही नहीं रहा है, ये तो सिर्फ फैट दिख रहा है. Yes, margins लिया है ना. Tumor is inside. We have a 1 centimeter margin cover around it. So that is the amount of margins we take. This was done under local anesthesia. Patient was not fit. This is the ovarian cancer. A story for this. I think we have some time. This is a very surprising story. A 27-year-old architect from Pune. She thought she was getting fat. She joined gym. जिम 6 महीना किया, कम नहीं हुआ. एक दिन इन जनरल पेट दर्द होने लगा. प्रॉब्लम क्या है इंडिया में? अगर कुछ अल्सर है, पेशेंट डॉक्टर के पास, डेंटिस्ट के पास नहीं आएगा. ब्रेस्ट में गांठ है, नहीं आएगा. पेट में कुछ गांठ दिखा भी है सोनोग्राफी पे, ओवरी में नहीं आएगा. जिस दिन उसको दर्द होगा, मुंह में अल्सर है, दर्द होने लगा है, यहाँ पे गांठ है, दर्द होने लगा, तब जाके वो आता है. सिमिलरली दिस 27-year-old फीमेल, उसके पेट में उसको लग रहा था वो बड़ी गांठ, पेट फूल रहा है. जब उसको दर्द हुआ, उसने सोनोग्राफी किया, तब जाके तकरीबन 15 किलो की गांठ थी, वो हमने निकाली, वो कैंसर की निकली. सो दिस इज अ प्रॉब्लम इन सम कैंसर्स वेयर वी डू नॉट नो अंटिल देर इज पेन. सो बी अवेयर, even slightest amount of symptom can be of a early cancer. This is about soft tissue sarcomas. I will not be emphasizing on other cancers. This is around 14 kg tumor which we removed from the abdomen. Some patients are really do not take care of their own health. I don't know how come they last for so long with such large tumors in their abdomen. Thank you so much for your time. This is the last slide. This is my OPD address. This is my timings. My OPDs are in Viman Nagar. This is my phone number. I do not share this routinely, but you being doctors, I can share it safely with you. My personal number is on your screen. In case you have any patients, any doubts, obviously we are going to solve them right now also if you have any doubts. And I have a YouTube channel by my own name. There are lots and lots of videos in Marathi, in Hindi, in English for patients and for doctors also. You can go ahead, see my channel. Any doubts, any patients you have, anything you think कि बायोप्सी कर, आपने बोला था उस दिन बायोप्सी हम कर सकते हैं ओपीडी में, मैंने इसलिए फोन किया कि आप गाइड करो, ऐसा ऐसा पेशेंट है. आई कैन गाइड यू ऑन फोन दैट हाउ यू कैन डू अ बायोप्सी इन योर ओन ओपीडी. जस्ट सेव दिस नंबर, कॉल मी, एनीथिंग यू हैव. This forum is now open for questions. Over to you, Dr. Pallavi.
Thank you, Dr. Bhushan, sir. Just wanted to check if anyone has any questions before we close out.
There's one questions regarding Dr. Pranjali Inamdar is trying to ask whether there are early cancer signs to see in oral cancers. Yes. Like I said, if there is ulcer you think which is not healing within 15 days, that is the first and last time you think that this is not cancer. अल्सर है, 15 दिन हो चुके हैं, you get a biopsy. Leukoplakia है, you you tell the patient there is a slightly increased risk, a 15% risk that this might convert to cancer. Erythroplakia, red patch है, there is a risk of 45% that this might convert to cancer. Depend on which 30 to 45%. So leukoplakia, erythroplakia. Apart from that, most common is ulcer. 15 दिन में अगर अल्सर नहीं भर रहा है, आंख बंद करना है, दिमाग बंद करना है, बायोप्सी कर डालना है. सिंपल. अर्ली साइन इज अल्सर.
I have one question, Dr. Bhushan.
Yes, ma'am.
Yeah, you had mentioned about the vaccination, right? The cervical cancer vaccination. It's better for from 9 years to I think 40 years or something, or
14, 14.
45,
1 4.
14.
Yeah.
Okay. What about 50 plus people? Do you think that vaccination would really be beneficial for anyone who is 50 and above, or is it something else?
So let me explain you the pathology of cervix cancer. Cervix
Okay.
cancer First of all, once there is a intercourse, the first intercourse is done, there is a start of infections. HPV infection might be there in your body. In many patients, that infection, HPV infection, is there throughout their lifetime. In some patients, over the age, that infection causes some cervicitis, like inflammation of the cervix, and that can convert into cancer. So basically, that vaccine acts on that infection. It prevents
Okay.
that infection to convert into cancer, or it prevents in the first place that infection to occur. So it has to be given in the tender age of 9 to 14, 9 से 14 साल की उम्र तक, when the chances of infection are zero. So,
Okay.
or at least before marriage or before first intercourse, so that it prevents that infection which is going to cause cancer. If you have not taken between that, you can take up to 45, because that is considered a reproductive age group. 45 is considered a reproductive age group. उसके बाद usually the reproductive cycle is not there. So it is
Yeah.
advised that 45 के पहले ले तो ठीक, 45 के बाद usually is not useful because the infection might already have been there in your body.
Yeah, true. Okay. The best thing just to do is pap smear.
Pap smear, yes. And
Yeah.
one more thing,
Okay.
as because you have raised this question, there is some
Yes.
question that हमने तो वैक्सीन ले लिया तो हमने पैप स्मीयर करना चाहिए क्या? Yes, vaccine prevents you from the infection. But if you are already infected, like if the intercourse is already done, then you have think यार मैं वैक्सीन ले लेती हूँ, अभी शादी हो चुका है, why not take, because सर ने तो 45 के पहले बोला है. So there is some infection already, some you are trying to prevent with the vaccine, so which already हो चुका है, उसके लिए पैप स्मीयर जरूरी है. So already even though you are vaccinated, पैप स्मीयर करना ही है.
So one more question from my side.
Mm-hmm.
Sir, you have told the relation of amenorrhea with the estrogen, that if you have less cycles, then less estrogen is there. Sir,
Correct.
in the cases of PCOD,
Mm-hmm.
we find less number of cycles, 8 or 9 cycles per year, generally found. So, are there less chances of cervical cancers in a patient of PCOD? Is there any relation of such
There is
kind?
no proven research on PCOD with cancer, but yes, logically, PCOD causes less amount of cycles because FSH and LH, the other hormones, are more. So the estrogen
Yes.
is less. That is why,
Okay,
yes,
sir.
we can come to a conclusion that yes, PCOD might be a cause that can reduce the estrogen and
But sir,
cancer.
in a patient of PCOD, we usually give OCPs and all to get them regular cycles. So is it right or not? Means, are there more chances of cancer if a patient is taking OCP for a long time?
So there's a difference between OCP and there's a difference between HRT. Hormone replacement therapy is a higher dose of estrogen which is given in postmenopausal women to reduce the postmenopausal symptom. OC pills have a standard dose, dose which is normally present in a female who has. Now OC pill have to be given to a PCOD patient or a patient having gynecological problems. So that is not a cause of cancer at all. OCPs are absolutely safe regarding to breast cancers or gynec cancers, the dose being very optimally calculated in OCPs. So OCPs are not a cause of gynec or breast cancer at all because the
Sir,
dose
if
is
any patient has got a history of hyperplasia anytime, hyperplasia of endometrium, and but now she is having regular cycles with the help of OCP, is there more chances of carcinoma there?
in the endometrium. Yes, it might change the aura there in the endometrium, but not regarding breast cancer.
Yeah, yeah, yeah. In the uterine cancer, there are chances, more chances.
There might be chance because
Cervical.
hyperplasia is already there, and estrogen or tamoxifen, the treatment given for breast cancers, might cause a risk of endometrial cancer because of the change in the hormonal aura. Yes. So
Okay, sir.
endometrium, yes,
Thank
there
you.
might be a risk, but not breast.
Okay, thank you, sir.
There is one more question, whether cancers are always painful. No, usually cancers are painless in the initial stage. In the later stage, when they involve the nerves or the nerve fibers, they become painful. I think that is answer your question, Dr. Anjali Runwal.
Dr. Bhushan, I have one more question. I'm sorry.
Yes, ma'am.
You had mentioned about the patient has had radiation, taken radiation for cancer. So it's better to not to do any extractions at least 6 months post the radiation treatment. What about chemo?
No, chemo doesn't have any problem of ORN, ma'am. In oral cancer, usually,
Yeah.
fortunately, chemo is only given for those patients whose nodes have an extranodal extension. The tumors are
Huh.
very aggressive. There's perineural invasion. So very less amount of patients undergo chemo for oral cancers. 80% of the
No, if the
patients.
patient is on chemo or has already had chemo for cancer, maybe it's just been 2 months for any kind of cancer, and the patient comes in for extraction. So, what are the precautions that we need to take?
It's a good
Are there
question.
any precautions as far as chemo is concerned? So, yeah,
Yeah,
thank
so
you.
if chemo is going on, if it's on chemo, if it's post chemo, the WBC rates is normal. If the WBC is in the range after the chemo is finished, there is no risk in dental extraction after chemo. If she is
Okay.
on chemo, WBCs come down a bit because the chemo is harsh in some patients. The patients are not able to tolerate. WBCs go down. In that case, the risk of infection is more. ORN is not more.
Okay.
ORN only because of radiation, the risk is more.
Radiation.
ORN, yes.
Okay. Thank you, doctor.
Thank you, ma'am. There's one more question. Reduced mouth opening due to tobacco chewing patient or smoking is also alarming sign. So reduced mouth opening is due to SMF, submucous fibrosis. So that is a different concept. SMF is also one of the pre-malignant in the cancers, but it is not a direct cause of cancer. So yes, reduced mouth opening causes one problem in detecting if there is cancer. So it is not directly related to cancer, but if there is a tumor on the retromolar trigon, which is causing the spasm of the oral cavity, yes. But if it is just a general submucous fibrosis and there is a mouth opening which has reduced, then there is a difficulty in finding if there is a cancer in the oral cavity.
गुड आफ्टरनून सर।
Yes.
सर जैसे जो टीएफओ के केसेस होते हैं जिसमें हम बोलते हैं कंटिन्यूअस नॉर्मल, पहले अल्सर से शुरुआत होती है टीएफओ में,
हम्म,
फिर बाद में अगर वो कंटिन्यूअस ट्रॉमेटिक रहे तो फिर इट कैन फॉर्म इनटू कैंसर। तो
हम्म.
आप इसकी पैथोलॉजी कुछ एक्सप्लेन करोगे सर?
Regarding the traumatic ulcers converting to cancer,
या लाइक अ थर्ड मोलर और द
yes,
टीएफओ,
it is
ट्रॉमा फ्रॉम
coming.
ऑक्लूजन।
Yeah. It is coming up that yes, traumatic ulcer, chronic trauma, like I mentioned in my second or third slide, is being a cause of especially lateral border of tongue ulcers. The chronic trauma, not only in oral cancer, is a problem, it is a problem in other cancers also. Like there are foot ulcers. There are some ulcers on the foot which later on convert into cancers. There are some ulcers in other parts of the body also which are due to chronic erosion. So yes, the mechanism is simple. Due to chronic erosion, there is inflammation, and inflammation is converting into cancer. Like I said, in cervix cancer also, the one apart from the oral cancers, the HPV is causing chronic inflammation. That inflammation causes conversion of some cells into cancer. Similarly, in oral cavity, the जो घर्षण हो रहा है, जो irritation हो रहा है, उससे inflammation होता है, and that inflammation is a cause of cancer. Yes, there is one.
सर
Yeah, please.
अगर वो समझो ट्रॉमा वाले केस में जरूरी है, मतलब पेनफुल ही होगा या नॉन पेनफुल कंडीशंस आल्सो लीड टू अ कैंसर
यूजुअली
इन
ट्रॉमा
द
में क्या
टीएफओ
होता है,
केसेस?
दे आर क्रॉनिक। ऐसे इमीडिएट ट्रॉमा नहीं, जिसने जीभ चबा दिया उसको कैंसर नहीं होगा। जिसका कोई शार्प टूथ बार 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 कंटिन्यूअसली हो रहा है, सो इट बिकम्स फाइब्रोज्ड, इट बिकम्स थिक। तो इन दैट केस यूजुअली इट बिकम्स पेनलेस ओवर टाइम, क्रॉनिक ट्रॉमा।
ओके, थैंक यू सर, गॉट इट।
Yes, and this lecture will also be on YouTube. Someone is asking about that. This will be on my YouTube channel also. One more question is there in patients with recurrence of squamous cell carcinoma in chin for reconstruction with PMC with rib, a good choice. Patient also have early interstitial. Yes, rib grafts along with PMC can be uplifted. I usually prefer a fibula if the patient is insisting for a bone flap. I prefer a fibula rather than with PMC. Yes, but if the patient is comorbid, having a lung disease, cannot go for a free flap, you might opt for a rib graft. I prefer in patients who are comorbid, I prefer a plate with a PMC. I do not use a rib graft. Someone has asked about my channel. So the screen right now, which is there, I think you can see my screen. That screen has my YouTube channel also. Somebody is asking about the channel. You can type my name and you can see my channel.
All right. Thanks everyone. Please do not hesitate to reach out to Dr. Bhushan for any questions and queries. His personal number is being presented on the screen. Please note that down for your reference. Thank you so much for this wonderful session, Dr. Bhushan sir. This session was certainly very informative and useful. We dentists look forward to interact and collaborate with you frequently. Once again, thank you so much for taking out time and joining everyone.